Good evening for today, my beloved colleagues. I hope all of you are fine by the mercy of Almighty. Just to check my voice, can anyone help me? Is my voice okay for you? Dr. Javed, Dr. Rashid is there.
Assalamu alaikum, Dr. Usman. Yes, very clear.
And the screen also visible
Yes,
well?
yes, screen also very well.
Okay,
Good
thank
visible.
you, thank you, thank you. So we are in time. We can start now. Let them others to join at their time. Thank you. Actually, what our intention today, it little different topics or only just to discuss something. It is not like a traditional class or session discussing a specific topic. But we are thinking the some evolution happened, especially if we compare the situations of UK and South Asian perspective. Uh, During AKT preparation also, you came to know that the MRCGP divided into different areas within UK, outside UK, and the topics they are considering the context of that geographic area. So it was very clear in AKT question topics, but in the OSCE also something possibly happened. This is my personal observation. I didn't share with actually anyone else in details, but it became true because I was following the different episodes of orientation by other colleagues in different mentors, especially the orientation given by the RCP before in some countries in the last few years. And I remember myself personally was oriented too much before in the beginning time with the MRCGP UK topics. And you know, the UK topics actually leading us. And the learning materials we have gone through for the AKT, basically all are designed for the MRCGP AKT UK purpose. But we are utilizing all the learning materials for South Asian or international perspective. So in this way, I will just try my best. I will be very humble actually to share some of my observations. If you have any difference in observation, definitely I will immediately respond. So with the few introduction, it's my pleasure again to introduce myself. All of you possibly know, and coming to the topic, again to let you know the name of our institute here. In the last session, those who attended, you know that we discussed about the OSCE blueprint as well as the mark sheets of the examiners. From there, the orientation directly given by the RCP, rather I like to say honorable mentors, they're giving the notes. Just for understanding, I am reading for all of you. The main aim of MRCGP South Asia exam is to improve well-being of doctors by mean of giving them postgraduate status and equip them with skills sets in order to enable them to provide higher quality of health care in comparison to non-MRCGP international doctors. Through a vigorously reviewed and quality assured process accredited by the Royal College of General Practitioners of the UK. So almost now you came to know the upgrades that happened in the last 1-2 years. The MRCGP South Asia right now currently not confined in the South Asia only. It is almost approved by the UK, Australia, and other leading Western countries also, or European countries. So the concept of exam structure understandings are a little bit modified. But some peculiar observation also I have with me, I hope I will share with you. And just to remind you, this is the sheet of the examiner where they are giving the marks, and they are giving the marks in 4 headlines. The number 1, 2, 3, 4 already you can remember it. And what some changes of understanding happen according to the skill, I will try my best to show you. Suppose this is the first thing, consultation skill. In the communication or consultation skill. So I told you before also there are 23 basic rules of consulting skill. Interestingly, I have collected it from the sources of MRCGP UK, not directly given by MRCGP South Asia or international. So there is no difference of understanding. These are the basic 23 points we have to learn, we have to practice. I just request you now to highlight something here about the jargons. Something happened, changes in the jargon. So far I have collected. Jargons means which point could be here? The choice of words actually, the choosing the words, number 11 point here. If you have the picture shot beforehand, you can see the choosing the words. Another point, psychological issues, the point 12, or the sensitive issues in the consultation skill, how to gather. So I like to tell you now the important thing here. Regarding the details of 23 points, this is the YouTube link for you to remind you. If you feel interest, you can go through there. On request, I can send it to the WhatsApp group or your inbox as well after your request later on, not now. So this is already given in 23 skills, the consultation, skills of the consultation, we have discussed detail. Another one here also, I like to highlight the point 14 is framing and meta communication. Another word is called signposting. Signposting, okay. So start with the signposting, very interesting. In the right side, I have posted the actually booklet given by the RCP orientation program. In the bottom part, you see this is marked, and I just I just make it bigger for better view. What we know before, that any sensitive information or it is called the private information in the consultation, we have to give a brief introduction that I am entering this sensitive issue. I hope all of you know. May I know, Dr. Javed, actually what I mean here? Suppose asking about the private relationship issue, how to introduce, how to start with first.
I think we will ask the patient that if you don't mind, I want to ask some private questions.
Exactly right that. In a different sentence, we can say that would you mind if I want to know some private information which is very important for your disease and its treatment. This will be a way also as well. There is another way also. Would you mind if I like to know something which I actually asked to all of my patients for their disease and its treatment? Many other ways. This introduction is called signposting. Signposting. In another word, in a proper consultation terminology, it is called the framing and meta communication. You can see point number 14, framing and meta communication. Just for easy language in English, it is called the signposting, just to direct, you know, the signposting there, the toilet is that area, luggage area in the airport by showing an arrow. So this is called the signposting. This was very basic in the consultation scale. But interestingly, I observed in the South Asian orientation, what they have said, the sensitive information is asked for in the same manner as routine medical symptoms, without signposting to the patient that one is entering potentially difficult territory. Dr. Javed, if I am not wrong, what you are thinking is the meaning is a little different here in the sentence. All of you, please be attentive.
Yes. Yes,
That
Dr. Osman.
yes, they are meaning that no need of signposting, right?
And yes, this is what is read. Yes, this is
Yes,
what is
sensitive
meant.
information asked for in the same manner as routine medical symptoms, directly without giving introduction. So I was thinking in the South Asian, if they have amended this scale, maybe there is some logic also. Understand? I was thinking by myself, when I say I give some introduction, if I give the signposting, possibly patient, there is a chance that patient would be more apprehensive. I don't know what is the psychology behind it. I was thinking by myself, but the basic thing was to give the signposting. Even then, I will cross check it with appropriate person if possible of the Royal College, because I have a colleague also attached with them. I can talk to him, but this is not like, as I have shown before, the 23 basic rules of consultation skill. This is the framing and meta communication. It is very interesting, and it is important also to make the patient prepared to give us their private or personal information. So this is one thing. That means directly, if it is true, according to the Royal College of General Practitioners, now we will ask the question directly. Like, do you have fever? Do you have cough? Like that. That means directly we will ask, do you have extramarital relationship? Right, Dr. Javed? Directly. Maybe. Right.
Yeah, yes, Dr.
Could be, could be. So today's, I told you before that today's discussion actually a little different discussion. Now the evolution in the jargons. Jargons. Dr. Javed, can you give some jargon words example we are using?
Yes, that is means medical term. Like we
Yes,
can
medical
ask,
term.
we asking patient that do you have pain in the epigastrium or in the
Yes,
right hypochondrium?
epigastrium, right
So that is
hypochondria. This is
the
jargon.
medical term.
Yeah.
That's
I ask you about the urine. Okay, what about your urine? If I ask in this way, is the urine is jargon? Dr. Rashid is possibly waiting to say, is the urine is jargon? Dr. Rashid, we cannot hear you. Dr. Javed, can you hear just to cross check? Why I cannot
yes,
hear? But Dr. Rashid having trouble, I don't know. Any other colleague? Or Javed also can say. Urine, is the
yes.
urine jargon?
Yes, jargon. Yes, it is jargon.
So what is the layman term?
Layman terms, I mean, water. Are you passing water, more water, or
Water, but we learned before the layman term is water work.
water work? Yes.
Water work. Nowadays, in the last few years, is my observation that the colleagues are sharing, as urine is a very common English word. Almost any educated people understand the word urine. So nowadays, especially I observed in the South Asian examinations and possibly in other exams, in the PACEs also, some simpler medical word becoming a layman term also. Understand, Dr. Javed? So if I ask that any problem in urine or any problem with your urine, I believe that nowadays they will not recognize it as jargon as before. That means by the examiner in the exam. Other colleague, do you understand what I say? Dr. Jan, Dr. Modi as well. I hope.
Yes,
I
yes,
hope. So in your understanding, suppose we are very used to say some words in our chamber with the people. Suppose if I say that some words that I will do an echocardiogram, usually most of the patient will not understand. But if I say, possibly I'm telling comparatively, I want to do an ECG of you, possibly some people may understand. What do you think? Please come to the discussion. I'm just comparing the words in the same topic in the cardiology, ECG and echocardiogram. Dr. Javed, are you busy? If not,
Yes, yes.
be connected. Suppose
No,
they our people, if I say ECG, they will rather understand a little more than the word I want to do an echocardiogram. This is my observation. I think, considering these things, many common medical words is no more jargon nowadays. I told you one is the urine, another is that ECG, or even I can say the X-ray of your chest. But the typical layman term of the X-ray, what is that, Dr. Javed?
For X-ray of the chest.
Yes. In the layman term?
I think it, chest photograph.
Photograph. It is not the photograph actually. We used to say the scan of the chest.
Scan.
But now come to the point. Now I recall myself and I criticize myself in one sense. Suppose in the abdomen, X-ray abdomen, what I can say? In the layman
Scan
term?
of scan of your tummy.
Yes, scan of your tummy. But ultrasound of abdomen? Dr. Modi, ultrasound of the abdomen?
Nice.
So there is a problem. Traditionally, ultrasound of the abdomen is said as a scan of the tummy. Okay? Understand, Dr. Modi and others?
Yes.
So
Yes, sir.
now there is a confusion. Which will be said scan? X-ray of abdomen, that means X-ray of tummy or ultrasound of the abdomen. For this reason, I think, I don't know what the intention behind the Royal College of General Practitioners personnels. They are making the words, commonly utilized words, as no more jargon. So I can say the ultrasonogram of the tummy. Okay. Or if I say for the ultrasonogram, scan of the tummy, but the X-ray, we will say X-ray of the abdomen. I think now it's clear. So X-ray of the chest, X-ray of the tummy, similarly X-ray of the head. Likely, I believe we can use now. We don't need to say the scan. So these are some jargons. So stool, urine, okay. Some test, suppose regarding the word test, I will do some test for you. In the Western world, they will appreciate it. But in the South Asian people, if I say I will do some investigations, if the person is not much highly educated, they will not bother. Okay. A simple educated person may understand investigations. So in the investigation, in my sense, is not much well understood word to make it layman term. So in majority, we will keep on the layman term to be utilized best. Who has actually gone through our discussion on the layman term? You can remember a lot of layman term we discussed in our discussion. So most of the layman terms are perfect till now, but few layman terms, what I have given the examples, you can utilize in general, but be careful. And still I believe if I use the layman term as before, it will not be actually discarded by the examiner. But suddenly if you say urine as urine, it will be accepted. It will be accepted. So these are some changes or evolution of the jargons in our communication skill. And now come to the data gathering issue. Regarding this immunization history, again, there is a jargon word also, the immunization. But is the vaccine, the word vaccine, is jargon or not? This is a question here. Dr. Modi, what do you think? Your country people, your patient in your area, do they understand the word vaccine? What do you mean vaccine? Do the people understand?
Uh,
People means educated people,
No, no, no,
higher
no, no.
class
In
people, they
general,
understand. But
in general,
in general,
in general,
no.
that
No.
don't they understand the vaccine? What they understand the word?
This is what we call tika. Means
Tika.
I don't know.
Yes, tika. Tika actually the good word, not for your country, your language. This is also approved in the Bangla language also. Tika. Dr. Javed, what do you say in your local word?
Local word here also they say tika.
Tika.
Yes.
Tika lagao, right? Tika lagao.
Yes.
So tika now is a very popular word, but in the exam we will not use tika. The English word in the layman term, you know, the shot, or somebody
Short.
say
Yes. Blue
jab,
short.
jab. American possibly say jab. Maybe UK and American there is some difference in the English wording. So shot or jab, especially we used to use the word shot before. But nowadays in the exam, so far I understand, we can use the word vaccine. That means I am asking the patient, did you get your vaccines, COVID vaccine, other vaccine? Because the vaccine word is now become more utilized, more used, but not immunization. Immunization definitely jargon. Anyway, but what I like to say here is the data collection on the drug history. When I asked about the vaccination, I can remember in our time, we are asking about the childhood vaccination, even in the elderly patient also. At that time, we are smiling. Why do we are asking the childhood vaccination at the age of 50 years or 45 years? That was a tradition at that time. And the surrogate used to answer, yes, doctor, my parents told. That was the answer. But now evolution or change is there. In the immunization history is, nowadays there are some established vaccine to be taken by the elderly people. Who can say, for example, 3 minimum 2 vaccine.
Pneumococcal vaccine, flu vaccine.
Yes, flu vaccine, pneumococcal vaccine, almost all the adults, especially those who are diabetes, immunosuppression or heart failure or the organ damage condition. So in this way, not to ask about the childhood vaccine, because in the age of 55 years, they are not very prone to develop the childhood disease. So in the drug history, in the data collection part of your consultation, rather ask the adult vaccination in the age of elderly people. So this is another changes in the data gathering. Now, in the focused examination, a much controversy there, and Royal Colleges are nowadays trying their best to make it clear. A patient having the cough. So what will be the underlying diagnosis? A patient having the shortness of breath, what will be the underlying diagnosis? For example, shortness of breath. It could be the lung disease, it could be heart disease. Okay. Suppose if it is the heart disease, a patient having the breathlessness, I am just asking you, any of you can answer. Is there any relevance to see the leg edema? Who can say?
Of course, because you are suspecting congestive cardiac failure. So leg edema. Sure, you have to examine.
Yes,
Leg
we have
edema,
to.
JVP.
We have to examine. So we have to examine leg edema. That means to see the complication of the heart failure, right? And if it is the lung disease, chronic lung disease, is it relevant to check the leg edema?
I think yes, because cor pulmonale, I mean,
Yes.
disease or any lung disease can cause cor pulmonale.
So focused examination does not mean only a specific area to be examined according to the symptom. That I said, the cough, primary disease in the lung, maybe COPD. So if I diagnose the COPD by inspection, palpation, percussion, auscultation, it's not enough. Focus actually does not mean very minimum examination. Focus examination means meaningful, targeted, pertinent examination. I am just going back to show you the slide. You see, the data gathering should be pertinent, should be in relation with the problem in question. Suppose a patient having the cough only without any abdominal symptom, no need to percuss, palpate most of the time the abdomen. But if you say that if I think right heart failure, we can examine the liver. Otherwise, the general examination of the abdomen not needed. Even if I come to the inspection, palpation, percussion, auscultation, there are some distinguishing observations in the examinations. You can remember the one sign in the chest palpation is vocal fremitus. Another one is vocal resonance. Is there any difference of meaning? That means the message you are getting by the fremitus and the vocal resonance by auscultation. Who can say? Dr. Javed again.
A vocal fremitus and vocal resonance. I mean, vocal fremitus is in, I think, palpation, and vocal
Method,
resonance
yes, the method is in
in
one is
auscultation.
palpation, another is auscultation. But the meaning, there is no difference. What we are getting the message by the vocal fremitus, the same message you are getting from the vocal resonance. This is a consolidation of the lung. One of the features of the consolidation of the lung. So nowadays in the clinical method, they are ignoring the vocal fremitus, keeping the word vocal resonance in the auscultation. So what I have told the story, in the inspection, palpation, percussion, auscultation, in the examination of the part, there are some meaning of the sign, they are having the similar meaning. So during the practice, in the discussion in the group, you can minimize these things. Suppose in the palpation, if you are getting one message in favor of the diagnosis, but if you get the same message in the auscultation, so you can ignore this sign elicitation in the palpation. You just straightforward get the message from the auscultation. I think I like to say in another way, suppose the rhonchi is there in the bronchial asthma. So rhonchi can be observed or detected only by auscultation. We cannot get it by palpation or percussion. So a suspected case of asthma from the history, if I go directly to the auscultation, it will satisfy as focal examination or the focus examination. Now I think you understood this point. So inspection, palpation, percussion, auscultation, all steps sometime not be needed, and all the sub steps or all the points of each headline also not always needed. This is the summary of focused examination. So try to remember it. Try to remember it. But in extension, you need to go beyond the area of your examination or targeted diagnosis also for exclusion of the complication or other comorbidities as well. Previously, we were thinking the primary diagnosis is enough. If I don't detect the complication, it will not be a major mistake. But nowadays in the South Asian exam, this is also important because you know that the profile of the exam quality now a little upgraded, I told you in my initial minutes. So the MRCGP, the RCGP telling that they are trying to maintain the quality at the level of MRCGP UK. So it is not actually the negligible thing we are thinking like before that, okay, this is not needed, this is not needed. So the profile or strength of the examination is being upgraded now. Okay, now to the examination or counseling, already I told you the focus examination issue. In the counseling matter, a little communication skill quality is also relevant. I told you the framing of consultation and other thing. In the management part, investigations, you see that we discussed before, we have to say the lay people language again. We discussed a little bit before that. We have to use the layman term, not the medical word in general. but some layman, the medical word become like layman term with us. Now, another issues of debate that I like to say, possibly I have to take a little more minutes here. A patient of diabetes mellitus is very common diseases. And my question to you, should we need consultation of a specialist to treat a patient of diabetes? Who can give the answer? Dr. Iram or others? Dr. Iram joined a little later. What do you think? As a GP, suppose I am a GP, you are a GP, do you need help from any specialist for the treatment of diabetes patient? What do you think? Sorry, cannot hear you. Any other colleague also? Dr. Iram, please. Sorry, voice not clear. Any other colleague can join. Dr. Javed, voice always good. Dr. Javed.
Yes, Dr. Osman, I think we should involve ophthalmoscopy, fundoscopy should be done. So we should refer the patient for eye examination.
Yeah.
Because you never know when you are diagnosed diabetic, the patient has complication already.
Yes. It is very justified
Retinopathy
answer.
or
It is very
nephropathy.
justified answer. But as a GP, I can start the treatment, is not it? As a GP, I can start the treatment by medication, lifestyle advice, and other. Is it, Dr. Javed?
We can start the treatment, but I think we should involve the other specialties as well.
This is the basic thing. I will show you the checklist produced by the orientation given by our CP personnel. There, I will give the summary of this. Not now. Again, like the tuberculosis also, the question is same. Can we start the treatment of tuberculosis as a GP? I am asking a critical technical question. Can we
Yes, sure.
start the treatment?
Should.
Yes. But should we involve in course of the treatment time any specialist here? Dr. Javed. Any
I think if there is
specialist?
complication or resistant TB, then we can involve. Otherwise, TB is so much common, at least in our part of the world, that in the initial part, no need.
Yes, this is the logic governing our personnel in the South Asian people, that simply they are telling GP should treat diabetes mellitus, GP should treat tuberculosis. But there is some further explanation what Dr. Javed said, that we can start the treatment, we can monitor the treatment like other subject, other diseases. We need to monitor the patient, and if needed in future, we will actually take the input from specialist clinic. Okay, I will show you later their checklist in their orientation program given. So referral means, you see that the GP's policy to the refer. Country to country, it varies. It depends upon the specialties available around. Like the countries in South Asia, in the rural area, I think that those who are from South Asian countries, colleagues today here, you will be agreed with me that in the very, very rural area, the referral is very difficult and almost not possible for the reason of geography, facilities, economic conditions, and others. At that time, GP is the person to treat everything. But this is not method, this is not science, or this is not recommendation on other. But whenever common facilities are available, GPs are to follow the rules, the referrals. And suppose in the Western rich countries, GP have the facilities to do CT scan, even the MRI. But in South Asian countries, is very costly and not available also. So it varies. In the variable setup, actually, we the GP become puzzled sometimes. And you may be puzzled in your exam also. Nobody is here to save you or understand. In the exam, what the checklist with the examiner, this is the final thing. It is not open all the time. Actually, never it is open as it is the checklist, but we can have an idea. We can utilize our IQ or level of understanding. But the thing is that we need to know the rules of referral as a GP. This is one thing. And after few years, the referral policy might be changed also. One thing. Now, actually, why should we refer? If diagnosis is confused, we refer. If any treatment purpose, what Dr. Javed said that additional treatment, I don't know or I am not confident to provide the treatment at that time, we need to refer. Sometimes we say the referral for special investigations also. So referral actually part of our day-to-day practice as a GP. Anyway, and where we are working, there are some words that GP practice, the word I am telling, GP surgery, GP clinic, and another word is specialist clinic. Just who can say in 1 minute, what is the difference between these words here? Any difference? Doctor Javed, GP practice means?
I think GP practice, GP surgery, GP clinic is the same, and the specialist clinic obviously is a particular specialist clinic.
Yes, what you say, this is the same, rather to say similar, not 100% same. The place to place, country to country, the terminology varies, but the concept is same. Somewhere you are sitting alone in your chamber. You are only one. Nobody is there. It is also your chamber, your practice, okay, and your surgery. But in some countries, few doctors together and made a GP center or health center. This is also GP practice, GP surgery, GP clinic. But a specialist clinic is separate. For example, hypertension, there are specialist doctor. Your chamber is not a specialist chamber. Okay, your chamber is GP's chamber. But nowadays, when you become the holder of MRCGP, in course of time, you will be a specialist family medicine, a specialist of family medicine. So in direct way, your chamber also will be a specialist clinic. But traditionally, a specialist means specific disease-related area, disease-related health center. And wherever all the facilities of the admission of the patients and others are there, this is the hospital. So you are working in your practice, in your surgery. If some facilities are not available, you are referring the case to the specialist clinic. So now the thing is that even in the poor country, also in the South Asia, there are some clinic called hypertension clinic. And diabetes center is actually well established. We say diabetes clinic. In layman term, we can say sugar clinic. And well established. Multiple facilities are there. In that case, should we refer the patient there or not? So our previous intention, those who are using the basic module also, if you observe our discussion there minutely, meticulously, you can see there that we had a tendency to say, yes, whenever I diagnose a case of diabetes, I will send the patient first to the diabetes clinic for proper evaluation, management, introduction, everything. Then I will follow the patient. But the evaluation in the Royal College understanding is that not as it is. You will start the treatment and then for further evaluation workup, you will send the patient to the sugar clinic later on. This is the message. Now, I'm just showing a scenario. What will be your decision? May I get the help from Dr. Javed? Can you read it, please? Just a question only.
Sure. A 54-year-old woman presents with postcoital bleeding. She underwent the menopause 4 years ago. You do a full pelvic examination, which is normal. Examination of the cervix is also normal. She has symptoms for 6 weeks. She has history of breast cancer and takes tamoxifen. what should you do? And these are 5 options.
Yes.
Should I read the
Everybody,
options first?
thank you. No need to read. Everybody look at the options and select your suitable one. What will be your best decision? Everyone have a look, few seconds and respond now. What do you think, Dr. Javed? I am just giving
Think
you,
C. Refer
I'm just
urgently for a specialist opinion.
opinion. Just I am giving the hidden message to you that tamoxifen have some tendency to develop breast cancer. Inner message I am giving you. Just to make our discussion fruitful for that. Now, do you like to revise your decision?
Then it will be E.
So you are thinking straightforward, your answer will be E. But what other possibilities were thought as a cause of, sorry, not I'm just correct, not the breast cancer. Tamoxifen caused that postcoital bleeding, that means internal genital cancer. There's the uterine cancer or cervical cancer. Sorry, not the breast cancer. She was getting the tamoxifen for the breast cancer. Okay, you know the tamoxifen is a old medicine to be taken by the patient later on. But we are dealing a suspected case of uterine cancer or cervical cancer. So at that time, which is better? But tamoxifen, this tendency, it is right. So Dr. Javed will be again the same opinion to stop the tamoxifen,
No,
right?
I think I'll still go for the C. The first time I said.
Why not stop tamoxifen?
Because tamoxifen doesn't cause. It could be carcinoma cervix. So tamoxifen does cause breast cancer, but
No. Sorry, I just corrected myself. I'm sorry. Tamoxifen is not responsible for the development of breast cancer. Rather, tamoxifen is a treatment of breast cancer.
treatment for breast cancer.
But we are dealing a case of postcoital bleeding. We are not dealing breast cancer. We are dealing the uterine cancer or cervical cancer.
Main problem is postcoital bleeding. So
Okay.
yes. So I think we'll refer her for urgently for a specialist opinion to rule out CS cervix or uterine carcinoma.
Okay. But you know that tamoxifen can cause the cervical cancer or the uterine cancer. If it is true, is not the best answer that stop the tamoxifen?
Because you have to choose one, Dr. Usman.
Now, I understand. But which is the best option? You are thinking the referral is the best option.
Yes, I think I will go for C.
C means urgently you are choosing just to give a 2 weeks time within. It is the thing, the difference between B and C. But as the tamoxifen may be a cause of the cancer, it could be an option also. But you are thinking this is the best answer. May I ask other colleague, what are you thinking? Any difference of your opinion here? Dr. Madi and other? Just to give you the clues here. Patient is in menopause, so it is a risky time. Pelvic examination normal, cervix also normal. Okay, patient is taking the tamoxifen. These are the key words to evaluate the postcoital bleeding. The decision what given by Dr. Javed is the best decision. Okay,
Yes.
that means in this case, specialist opinion is important. But as a GP, if I stop the tamoxifen, it may be true. What I mean that if GP knows always that, okay, it may be the risk, I can treat the patient always. It may not be true all the time. Referral sometime needed. That I mean, there might be raising of confusion regarding the referral or straightforward treatment given by the GP. Then it will be very unfortunate. So things are variable, and that the topic concept today is the evolution or changes in the decision making by the GP is under evolution. That we are discussing today. So you see, tamoxifen increases the risk of endometrial cancer. This is true. Even then, as a rule, for the cancer pathway, we have to follow as a GP. If I stop the tamoxifen, if I don't refer the patient, it will not be a correct decision. And you know, for the cancer treatment, there is a specific indication for the referral, especially in a suspected case of cancer. We have to follow. Okay, now, this is the basic principle of the referral. I am just reading for you. Apart from accidents and emergencies and a few open access clinics such as genitourinary medicine, if patients need to be seen by the hospital doctor, they have to be referred by a GP. So there is a difference between clinic and hospital. So if you have clinic facilities surrounding you, you can send the patient to that clinic. So that I like to say, there is tuberculosis clinic, hypertension clinic, diabetes clinic, right? Memory clinic. So memory clinic is not much well established in South Asian field, but the hypertension, diabetes, these are well established. In such cases, better not to refer to the hospital, rather we can refer to the clinic after giving some treatment by yourself. So these are the common diseases. My suggestion and what I say request to all of you. For example, in the systems, common disease, hypertension, diabetes, tuberculosis, COPD, asthma, we need to know about the guidelines. And wherever the guidelines are available, a GP can start the treatment according to the guideline. This will be the principles of our understanding. There may be other diseases, common disease rather to say. Again, it is non-specific, which will say common and which guideline. But there is no doubt that these are common diseases and we must know. We must know. But regarding the treatment of Parkinson's disease, regarding the treatment of multiple sclerosis, Dr. Javed, what do you think? Is it much common and GP can treat, GP can handle? What do you think? There could be some guidelines by the NICE. Dr. Javed. Apparently, we need to have a power of understanding which diseases are common, and those diseases should be in our hand according to guidelines. Suppose for hypertension, right? It's the step 1, step 2, step 3 treatment. A GP can do. In a step 4 also GP can. Sometime GP is to refer the case. So according to the guideline, we can treat. That is actually nowadays expected by the Royal College examiner. We are at the end, don't worry. The therapeutic trial by the GP. I have gone through their observations by the Royal College that GP can give a therapeutic trial. I tried my best to understand the meaning. But in my sense, therapeutic trial in some time may be dangerous. Without the confirmed diagnosis, GP better not to start a therapeutic trial of the disease. But in some cases, what I mentioned here, you can see, regarding antihelminthic treatment, mebendazole, albendazole, apparently those medicine does not have very dangerous side effects. But anti-tuberculosis treatment have side effects. And it is a debate area to give anti-TB treatment. We need to do, as Dr. Javed said, in South Asia, the tuberculosis is more prevalent. But the treatment is not simpler. So debate will be there, controversy will be there if GP start the therapeutic trial for each and every disease treatment. This is my humble suggestions. Though Royal College have tendency that GP can give therapeutic trial, but my suggestion to make a mixed attitude or decision making. Antihelminthic, for example, we can give, but not for anti-TB or even suppose the cancer, nobody will give the treatment. Okay, therapeutic trial. So we need to be aware of that for the therapeutic trial. Now, lastly, the checklist needed or not for our reading. Yes, checklist needed. This is one of the checklist, not for your OSCE, remember. I just have collected to show you this type of checklist important for a specific exam. This is a different exam, not your OSCE exam in South Asia. There are many points are not there. They develop some points in very junior level from 27 points. If you go 17 or 18, you will pass in this station. So it is not covering all the requirement for the OSCE exam, OSCE station. Now, what about the RCP personnel's checklist? For example, they have given breaking bad news, consultation skills are almost same in each station. Data gathering for the specific. What about the scenario? Scenario was actually a baby 7-year, newly diagnosed diabetes mellitus. The father or mother is with the patient with the report. During discussion, this is the checklist developed by the examiner. If you don't have, you can make a snapshot. Okay. Now come to a point here where I am moving my cursor. In the management and investigation skills, the negative score you will get or negative impression be created here. If you refer to endocrinologist, it will be a negative scoring for you. Dr. Javed, do you understand now what is the meaning?
Yes, Dr. Usman.
Because baby diagnosed now diabetes mellitus, possibly type 1 diabetes. So if you refer the baby to endocrinologist, you will lose your marks or you will not get the mark. What does it mean? You need to start the treatment of diabetes of the baby. This is the expectation. Now, if type 1 diabetes, you need to start the treatment with the insulin plus minus glucophage. Glucophage, you understand, is a very well popular trade name, metformin, glucophage. Actually, you need to say rather here metformin, not the trade name. Mistakenly, it is printed as such. Anyway, so insulin you need to start today. But as I said you in our previous understanding, that wherever the diabetes, at first I will send to the diabetes clinic. It will not be justified. So we need to follow a mutual mixed pattern of management. I will start, then I will refer. So there are some treatment, common diseases, the Royal College expect GP should know almost A to Z of the disease, but not too much extensive like a specialist. I like to say similar to a specialist, not same as a specialist as endocrinologist. I hope you understood my technical wording. So this is one checklist for the breaking bad news issue. So it is not the time to discuss breaking bad news. Just this is an example. They're all are the consultation skills they have mentioned here. Okay. Now the second scenario, end of life care. Terminal lung cancer, patient refused curative treatment, and he knows that he is dying. Patient knows that he is dying. But you are talking to a proxy. Proxy. I explained proxy in the last class also, that on behalf of the patient, somebody is talking. So there is some other thing, legal issues, ethical issues. But thinking is that the here referral, inappropriate referral in the last word in the management part. Referral means, should I refer? He accepted his death. He doesn't want further treatment. Even then I am referring somewhere for the treatment. It will not be justified. It will not be justified. So wherever scientifically referral needed for the palliative care, sometimes referral is not needed. Not needed. And here, Mr. Arshad, case reference is Mr. Arshad. If you are talking to the son, daughter of the Arshad, we need to know about the permission, that Arshad given permission to the relative or not. This is also important here. Okay. And another one, Mrs. Fazina, the report showing AFB positive. Okay. But she is here with the report of mother-in-law. It is also, if it is a proxy, then we need to know the permission taken by Mrs. Fazina from her mother-in-law. Okay. And the views of the mother, it is important. So it could be a case of ethics, the confidentiality or not. Okay. Now, Fazina is confused that this is the AFB positive, but Fazina thinking or mother-in-law thinking, could it be cancer or not? So breaking bad news and other important. Explanation of the station is important, and how to give the explanation. Already I have discussed a little before in many my previous videos, the YouTube also. So you can see there. So I am showing you the checklist, importance of the checklist. Suppose I am showing the checklist of such cases. You need to learn now more than 100 cases. So should you make 100 checklist, Dr. Javed? You are a very good colleague and you are responding. I'm asking you all the time. Do you think that more than 100 checklists should I have?
A basic checklist should be there, then you can improvise.
This is your kind opinion, very nice opinion, because the 100 and 150 checklist will make you puzzle actually. It will conflict each other. You can practice when you there's some writing in your paper to write something for your better inbuild, to make inbuilt of the memory or information in your brain. But if you make a note for the checklist, so you will be a robotic person. And the Royal College wanted that a doctor should be a human, not the robot, not a machine like checklist. I have gone through their observations. They said that when a case in the station and candidate facing, they are asking like a robot, or they are following a checklist in their mind. For example, I discussed a little in the last class. Again, I am repeating because it is very important. Just follow my talk, Dr. Javed, especially, and other colleague also you can share. I am telling as a patient, doctor, I am much worried about my cough. So what messages you are getting, Dr. Javed? You got one symptom, that patient having cough. Is there any other message?
I mean, it's just the cough, or the already diagnosis and
No,
cough.
no. Diagnosis is not there. It's just a clinical station. Diagnostic challenge is there. You will diagnose the case. But patient telling, doctor, I am much worried for my cough.
Obviously, they will ask questions regarding cough, and then accordingly
No. You will diagnose the reason of the cough, no doubt. But is there any message from the patient talk? The very beginning, when you say, how can I help you? Patient telling, I am worried for my cough. Is there any further message you are getting? So this is the test for you, everybody. Yeah, Dr. Modi.
I think it give message which systems are involved. Maybe it is a respiratory or cardiovascular.
Okay. But in the consultation points, 23 points, is there any message of idea, concern, expectation?
Yes.
Be serious. The Royal College observed these very strongly. And I also observed, those who attended our previous discussion in the OSCE, you remember, when I surrogate the case, I utilize this clue sometime.
Yes, idea. I mean, you will ask, what do you think your problem is?
Yes. Which word indicating that there is a message of idea, concern, expectation? I am repeating the sentence. Doctor, I am much worried for my cough. Which word
Worried.
telling you? Yeah, Dr. Modi, this is the worried. So in the worried, there is a hidden message that patient is willing to say you his or her concern. So what will be the next question here? After finishing the cough or before elaboration of the cough, you can start with the talk worried also. So how to ask? Yes, Mr. John, can you tell me why you are much worried for your cough? Then what answer could be there, Dr. Modi, Dr. Javed also? Yeah, doctor, I am worried that I might have cancer in my chest. You will get this message there. That Royal College examiner observed, you are not addressing the message there in the first sentence. So you are elaborating the cough, you are diagnosing the cases. At the later part, you are asking, Mr. John, why are you worried for your cough? That means, like a checklist, you are following like a robot, you are following these, and at the end, you are asking idea, concern, expectation. That is their observation. That means you are not following the patient. Rather, you are following your checklist. Clear now, Dr. Javed?
Yes,
It
that
is
means you
not-
can go like idea, concern. ICE you can do before also instead
if
of
you have
in the
if you have the
practice.
clue, if you have the clue in the patient's talk.
So
Similarly,
no
patient
need
tell
to follow
you,
exact
yeah,
checklist.
patient tell you, doctor, you see that I am having the cough despite I am getting the antibiotic. So what message you are getting? Additional message. You are getting additional message, something from the drug history, isn't it? But if you ignore it, though patient telling I am getting antibiotic, you are not asking the antibiotic right now. You are forgetting it. You are not attending this issue. You are going stepwise in your checklist. Then you are asking, what medicine are you getting, Mr. John? So what is the meaning? Meaning that you are repeating. You are duplicating the messages from the patient. The patient will think that you are not attending the patient seriously. Clear, Dr. Javed?
Dr. Usman, clear.
Yes. This is, and most of the time we are doing, I can say, because I observe our previous colleague in our OSCE station, I just alerted them most of the time, even then, they couldn't become more serious to avoid this thing. So be aware of that. The summary word is that I have to be with the patient, not with the checklist. Even then, checklist is helpful for our memorization. Okay. So this is checklist in summary. I like to show you. This is the examination points, general examination. This is the history headlines. This is the examination, and this is the summarized checklist. What Dr. Javed said, this is our basic checklist. With our capabilities from Almighty, with our limitation, we developed it for you. So you can utilize it, including this thing also. We cannot claim it is 100% right. If you have the better one, you can share with us. Here actually will be the 4 ID, not the 3. It will be the 4 ID. 4 ID means this there. Elderly, we need to know about the 4 points. So I am requesting all of you to make the snapshot. I believe it will be helpful for you. So this checklist you keep in your mind, basic one, but as a reference, you keep this thing in your mind. Accordingly, you reshuffle the point informations given by the patient. You delete first, then come to the next, not like a robot or the machine 1, 2, 3, 4, 5, this 6. You can make it up and down according to the patients. I hope it will be very helpful for you. So this is my last word of basic discussion of today, and this is invitation for you in the coming Chennai. Already you have seen in the group, just for your kind reminder. And again, I don't know, I hope all of you in the member in our group, even then as before, I am even 1 or 2 there also in the chat box. I am giving the WhatsApp link. If any remaining, my colleague, you can join here. And those who are not appearing the Chennai, you can go through this module. And this module always in upgrade and modification addition. Those who are using, I hope you are getting the benefit. So with these few words, I like to conclude today. If you have any question, queries, you can ask me now for a few minutes. Any comment, any issues, miscellaneous you can raise today. Anyone, please? Or regarding this topic today we discussed, is it useful? Minimum, you can say this to me. Otherwise, I will be actually that was frustrated. My time should be utilized for your benefit, right, Dr. Javed?
Yes, thank you, Dr. Usman. It's very, very, very useful.
So if it is useful, you can share with your colleagues. I hope we could make a link of the class today, and we'll give the link in the WhatsApp also, so that other colleagues, those who couldn't attend the session today, they can join and they can get it. So thanking you. And I believe that today's discussion is very extraordinary, no doubt. And this observation may not be available in anywhere also. This is my personal observation as a mentor, as a colleague rather to say. So thank you very much for your patient hearing to me and participation for today.